Yes.
Yeah, there is no relevance at all having, yeah, the low TSH reflects the fact that he is panhypopituitarism and not secreting TSH. Thus, the important level to monitor in his T4 concentration and ensure that this is the normal range. His osteopenic bone mineral densities on dual energy X-ray absorptiometry may be a reflection of his hypogonadism. This appears to have developed since he has received a radiotherapy for the residual pituitary tumor. Replacing the testosterone is the first instance, is the most important maneuver in preventing the further loss of bone. There is no relevance in giving bisphosphonates as he is on the replacement dose of steroids, not treatment dose, and is not osteoporotic. Also, growth hormone therapy is licensed for the treatment of symptoms with reduced quality of life on adult growth hormone deficiency assessment questionnaire score, rather than as a treatment for bone loss. The most effective treatment, therefore, to improve the bone mineral density in this patient's case would be testosterone therapy. Next. What is the most like what is the most likely cause of the abnormal thyroid testing? A 17-year-old female blood taken for endocrine testing. LH low, FSH low normal, total T4 170 high, free T4 7 low, TSH 0.7 normal. Total T4 is very high. So what is the most likely cause of abnormal?
Pregnancy.
Hmm?
Pregnancy.
You mean without prolactin? Okay. Pregnancy blood results show high estrogen, low LH, FSH, and elevated prolactin and beta HCG. This patient is clinically euthyroid but exhibits the common changes in the thyroid's homeostasis seen in pregnancy. Thyroid binding protein production is increased, possibly due to the action of estrogen on the liver. Total T3 and thyroxine T4 are also increased in compensation, but free T4 action. Thyroid stimulating hormone is often slightly decreased or low normal, perhaps as a result of HCG being increased during pregnancy. Other hormonal changes that occur in normal pregnancy include increased cortisol binding globulin, increased free and total cortisol, increased aldosterone, prolactin, estrogen, which can lead to low LH, FSH, and progesterone also will be increased. Anorexia nervosa can be associated with the suppressed LH-FSH hormone, but would not account for the high total T4 and low FT3, low free T4. Hypopituitarism is associated with the low or low normal TSH and low. Everything will be low because of hypo.
Acromegaly.
Which of the following investigations would be most appropriate? 55-year-old female referred with hypertension. She has been hypertensive for over 4 years and control has been difficult despite the combination of atenolol 50 mg, lisinopril 20 mg, and benzoflumethiside 2.5 mg daily. Examination reveals the appearance as shown in the blood pressure of 180 by 90 and a pulse of 66 per minute. Which of the following investigation would be most appropriate? Random growth hormone concentration, insulin-like growth factor 1, renal ultrasound examination,
GF1 ولا glucose test
IGF-1
most
for the growth
appropriate.
hormone. Okay.
الموست appropriate ده صح؟ مش كده؟
Mm. Abnormal GTT and growth hormone measurement is diagnostic of acromegaly. The patient appears acromegalic and hypertension may be a presenting feature. The most appropriate investigation would be an oral glucose tolerance test with a growth hormone measurements. Suppression of the growth hormone concentrations below 2 mu per liter would be expected in normal patients with a non-suppression of paradoxical elevation seen in acromegaly. Suppression of growth hormone concentrations below 2 mu per liter would be expected in normal patients with the non-suppression or paradoxical elevation seen in the acromegaly. Elevated IGF concentrations would be expected, but this is not diagnostic. What is the best management strategy for this patient? A 69-year-old man reviewed at medical outpatient clinic complaining of tiredness, neck tenderness. 6 months ago, he was admitted with angina associated with atrial flutter, which spontaneously settled following intravenous digoxin. Since then, he has been treated with amiodarone 200 milligram daily. He also takes aspirin 75 mg daily and atenolol 50 mg daily together with the this is atorvastatin type 40 milligram daily. Recent 24-hour ECG shows sinus rhythm throughout the occasional with the occasional ventricular ectopics. Examination of the patient reveals fine tremor, pulse 56 beats per minute, and BP is 146 by 88. Next examination reveals no obvious goiter but mild tenderness in the thyroid area. Plasma free T4 is 33 high. Plasma TSH is less than 0.02 suppressed. What is the best management strategy for this patient? Stop amiodarone and start steroids. Stop amiodarone and start carbamazole. Stop amiodarone only. Stop amiodarone and start carbamazole and flecainide. Continue amiodarone and start carbamazole. So patient has a hyperthyroidism, most probably drug induced. So we have to stop amiodarone and this is type 1. Amiodarone induced thyroiditis. His pulse is now controlled. He is not in AF anymore. Type 1, yes, carbamazole. Stop amiodarone and start carbamazole. Not type 2, this patient.
Why it is type 1?
Because
ليه type 1؟
patient has a fine tremor. Patient has a fine tremor, symptomatic. She has neck tenderness and tiredness. Huh?
She has neck tenderness. She has no goiter. Yeah. أيوة amiodarone induced لكن which type؟
Patient is hyper.
لا ما بتجي هايبر لكن ليه where is goiter؟ ليه examine reveal no obvious goiter. No obvious goiter.
Hyper, I told from the labs. Free T4 is high, 33.
Yes, I know that, but maybe thyroiditis, yeah? Why it is type 2, type 1. ليه type 1 يا جماعة؟ ما في obvious goiter. شنو؟ ما أعرف إذا عندكم قائمة تانية. سنة. مهم. مهم. Look tenderness going with thyroiditis, not with مهم. Where are you؟ شكل عنده مشكلة في الكونكشن. واحدة تانية ممكن تقرأ؟ ممكن حد تاني يقرأ يا جماعة، عنده نت كونكشن. أها. طيب.
Yeah. My connection also dropped. So amiodarone-induced thyrotoxicosis is due to thyroiditis and can be treated with steroids. The patient has a probable amiodarone-induced thyroiditis. So as you mentioned, yeah, there was no goiter. There was no obvious goiter, so it is type 2. If there is goiter, of course, it is type 1. Yes, you want to read this, Doctora? Hello? We have to read this because already this is same explanation. Yes. Which of the following is the most appropriate investigation for this patient? Most appropriate investigation. Okay. A 26 years old young female presents with a 3-month history of weight loss and generalized general lethargy. She has a 5-year history of type 1 diabetes mellitus, for which she has been treated with a basal bolus insulin consisting of short-acting insulin thrice daily and long-acting insulin in the evening. Commensurate with her weight loss 5 kg over the last 3 months, she has noticed that she has recently encountered more hypoglycemic events and has reduced her insulin requirements from 60 to units per day to 38 units daily. She takes no medication other than oral contraceptive pills. She is a non-smoker, denies use of any illicit drugs. On examination, her BMI is low, appears comfortable. Her pulse is 68 per minute. Regular BP is normal. There are no specific abnormalities of the chest, heart, or abdomen, but has a slight purplish yellow, non-tender, 2 to 3 centimeter well circumscribed papules on both sheaths. Urine analysis are normal, hemoglobin normal, white cell count normal, random glucose high, lowish no, normal actually. HbA1c is 50. 6.7%. Plasma sodium is 135, potassium is 4.5, urea 5. Which of the following is the most appropriate investigation? Thyroid function test, abdominal ultrasonogram, synaptin test, variant meal with the follow-through, anti-endomyocele antibodies. Sodium 135.
She has weight loss lethargy,
Mm.
type 1 diabetes, yeah.
Yeah,
She
frequent
experienced issues بتاعت hypoglycemic, yeah.
yes, frequent hypoglycemic episodes will
Her
present with
insulin
type 1
requirement
diabetes.
reduced from 60 to 38 unit only.
Yeah.
بس what about البربشيل non-tender circumscribed babule? It is the Graves' dermopathy.
Tender,
I was thinking
non-tender.
orange
yellowish دي
peel.
microbiosis ليبوديك ولا ايش دي كمان؟
What?
Foolish yellowish non-tender.
It needs thyroid function.
وين الثايرويد فانكشن؟ الثايرويد فانكشن هي ويت لوس وليثرجي، يعني بقت ثايروتوكسيك البيشن عشان كده بقت تجاها هايبوجلايسيميا.
Yes,
الانسولينوم بتجي
so
بويت لوس، بتجي بويت لوس الانسولينوم.
but it's not tachycardic. She also didn't
ثايرويد
have anemia.
تست.
of Addison.
أيوة بس ما في
That's
حاجة.
normal. It's mostly يعني thyroid function.
Complicated question, this one.
الستيرويدز اللي بيخليها تبقى هايبوجلايسيميك شو؟ ليه تبقى هايبوجلايسيميك هي كانت يعني diabetic
Doctor, for me,
بس كده body mass index very low. إيه؟
this papules is most probably from OCP induced erythema nodosum. I feel so. So we are dealing with recurrent hypoglycemic episodes with
مم.
weight loss.
كده
So
يلا
most
خير.
probably this is hypoadrenalism. Yes.
سمعت. Add this one. Patient with type 1 diabetes become hypoglycemic decrease the needs of insulin غالبا بتكون Addison disease. even if أداك البوتاسيوم الصوديوم والبوتاسيوم within normal range. مهم.
Yeah.
You have a connection problem.
My signal was lost. Okay. The silent features this young woman. Do you want to read this? Because it is already established. Type 1. So Addison's also autoimmune. The silent features in this young woman. Okay. Next. Which of the following agents should be selected to improve the blood pressure? Treatment for BP. Okay, 39-year-old man comes to the clinic with resistant hypertension. He is currently managed with ramipril, amlodipine, and his BP is 155 by 98. His BMI is 22. There is no medical history of note apart from the mild asthma for which he takes salbutamol inhaler. Uncontrolled hypertension with a normal BMI. Hemoglobin is 13.6, white cell count is normal, platelet normal, sodium normal, potassium low, creatinine 129, renal impairment is there. Ultrasound abdomen show right adrenal adenoma. Surgery is being planned for his adrenal adenoma. Which of the following agents should be selected to improve his blood pressure? Bisoprolol,
Spironolactone.
spironolactone, indapamide, nebivimol. So it is a spironolactone.
Yes.
Next, straight question. So in Corn syndrome, aldosterone inhibition with spironolactone will bring the greatest additional reduction in the BP. The most likely diagnosis in Corn syndrome leading to hyporeninemic hyperaldosteronism. The ultrasound scan and hypokalemia on angiotensin converting enzyme inhibitor support the diagnosis of Corn syndrome. Aldosterone inhibition with spironolactone will bring the greatest additional reduction in the BP. None of the other options are direct aldosterone antagonists. As such, they are not effective in lowering the BP in Corn syndrome, as is spironolactone. What name is given to this appearance? Patient is admitted with the central abdominal pain, eruptive xanthoma, adenoma sebaceum, condyloma acuminata, chickenpox, tuberous gout. Yes, eruptive xanthoma and pancreatitis. Eruptive xanthoma beta occur in hyperlipidemic state associated with a hypertriglyceridemia. Typical lesions of eruptive xanthomata are shown, raised lesions typically occurring on the external surfaces. Eruptive xanthomata occur in hyperlipidemic states associated with hypertriglyceridemia. Well-recognized associations of hypertriglyceridemia include acute pancreatitis and lipemic retinalis. You want to read?
I memorize the rash in that patient with Addison. Just I go back to see
Yes,
what
microbiosis,
what
the
it says.
rash on the shin.
Microbiosis. Yes. Okay.
A 53-year-old man with the type 2 diabetes mellitus is initiated on insulin. She is currently taking metformin 1 gram BID and glycoside 160 milligram BID. An intermediate acting NPH insulin is to be started once a day at night. Which of the following most appropriate advice to give regards her oral hypoglycemic agents once the insulin is started? So she is on metformin 1 gram BID, glycoside 160 milligram BID along with NPH. Both metformin and glycoside can be continued. Both metformin and glycoside should have their doses halved. Both metformin and glycoside should be stopped. The metformin should be stopped and the glycoside can be continued. The glycoside should be stopped and metformin can be continued. But we don't have a criteria what to stop, whether neither insulin nor, no RBS, no HbA1c. Both continued.
Can be continued, yeah? No need to be stopped. Why stop? Metformin, glycoside, intermediate insulin to be started once a day. No problem, yeah? They can be continued.
Okay. Oral hypoglycemic agents can generally be continued when insulin is started. Metformin is widely used and continued alongside insulin, as there is evidence that it is beneficial in reducing the amount of insulin needed, and also for its weight and cardiovascular benefits. Sulfonylurea can also be continued with insulin. If the patient is taking a daily isophane or analog insulin, it is continued at that same dose with the monitoring. With other insulins and regimens, the dose can be halved or the sulfonylurea discontinued if desired. Hypoglycemia is the biggest fear with using a sulfonylurea with insulin, so greater caution needs to be exercised in vulnerable patients like elderly, dementia, and those who live alone. DPP-4 inhibitors like pioglitazone, glucagon-like peptide hormone with one agonist, and SGLT2 inhibitors are all half, the dose should be half in their respective classes that can be continued along with the insulin. Agarabose is not recommended in combination with the insulin.
Why? Why
Because
acarbose is not recommended?
it increases the hypoglycemic episodes. Okay, what is the most likely underlying cause of this?
Why?
What is the most likely underlying cause of this abnormalities? A 54-year-old man has referred to the medical outpatient clinic for assessment of fatigue. He gave a 6-month history of generalized malaise, feeling tired all the time. He had a past history of hypertension that had been monitored by his GP, but this had not required treatment. He had also reported feeling in a low mood to his GP, but attributed to the fatigue. So hemoglobin was normal. So easy fatigability. For the last, he's tired all the time since 6 months. WBC count is normal, platelet normal, MCV high, sodium lowish normal, potassium normal, urea normal, creatinine 110, upper limit of the normal. Tiredness with high MCV with the normal hemoglobin, with hyponatremia. Down.
Hypothyroidism.
No, still more. Total bilirubin high, total protein normal, albumin normal, alkaline phosphatase high, AST high, gamma GT very, very high. 9 a.m. cortisol is very high, 12 a.m. plasma cortisol 720, that is midnight cortisol is high. 24-hour urinary free cortisol is also all high. So he's Cushing's, right? With ectopic secretion, gamma GT, alkaline phosphatase, high cortisol, easy fatigability, potassium was 3.9, right? Or 3.2? 3.9, normal. The high bilirubin, here's multifactorial here. Alcohol, gamma GT was high. Gamma GT is very high. Acute 299.
What you means? What?
Gamma
She's
GT.
drinking alcohol?
Huh? He,
So
I
past
used,
medication of hypertension. ما
yeah, the
نختلف على شيء she has not required treatment
alcohol,
source.
alcohol will cause high MCV. Small absorption.
Yes.
Alcohol will cause high MCV, and in the LFT, AST, ALT is high. I mean, AST is high, alkaline phosphate is high, gamma GT is high. So this is alcohol
Glucose.
induced. Yeah. So this is alcohol.
So the Cushing?
Glucose alcoholic hepatitis.
Yeah.
You mean so the Cushing, yeah?
Yeah, pseudo, yes.
Mm. Yes. Excellent.
That is all. Okay.
Okay, pseudo-Cushing syndrome resolves rapidly with abstinence from alcohol. The patient has alcohol-induced Cushing syndrome. It is usually mild and disappears when the underlying disorder is resolved. Due to the high prevalence of alcohol abuse and the possibility that the test results may be identical to those with the Cushing's disease. Clinicians should be familiar with this disorder to avoid misdiagnosis in the and start the inappropriate therapy. The mechanism of hormonal abnormality may be due to increased CRH secretion or impaired hepatic metabolism of cortisol. Hormonal abnormalities disappear rapidly during abstinence from alcohol. This may be difficult to distinguish from true Cushing's, but the most likely cause here is alcohol. The raised MCV is helpful in this context. Next. Okay. So what is the most likely visual field defect in this case? Maybe pituitary. The 15-year-old boy presents to the ER with the polyuria, polydipsia, chronic headaches. He also states that he has noticed some difficulties with his vision of late. He has no significant past medical history. Examination reveals he appears well. BP is normal, pulse normal, temperature 36.8, pupils equal, reacting to light, accommodation. Fundoscopy did not reveal any abnormalities. Hemoglobin normal, white cell count normal, platelet normal, sodium high, hypernatremia, potassium 4.1 normal, hypernatremia with visual field defect. Serum urea is normal, creatinine 67 normal, fasting glucose 5.4 normal. Urine analysis pending. What is the most likely visual field defect in this case? Binasal hemianopia, left inferior quadrantopenia, left superior quadrantopia, and inferior bitemporal hemianopia, superior bitemporal hemianopia. What is the clue we have here?
It's mostly craniopharyngioma.
Cranial, only with hypernatremia. He has polyuria, polydipsia, and chronic headaches.
Yes. Polyuria, polydipsia, and
Diabetes
headache.
Yeah,
diabetes
so
insipidus. عندها diabetes insipidus مع
central diabetes
difficulty in vision
insipidus with the
وطبعا
hypernatremia.
بالتمبرة.
Yeah.
الكرانيوفارنجيوم بيعملها inferior
craniopharyngioma. It's
inferior inferior bitemporal.
inferior bitemporal.
Yeah.
Yes.
Yes.
Cranioparenchyma causes inferior bitemporal hemianopia and central diabetes insipidus. The patient has a cranioparenchyma which is causing headaches and central diabetes insipidus. These brain tumors typically arise in the cellular and in the cellular supracellular region. They sit above the optic chiasma and can therefore cause inferior bitemporal hemianopia. Superior bitemporal hemianopia would be more commonly seen with the pituitary tumors. Inferior quadrantopia and is seen with the parietal lobe tumor, that is PITS. We know the mnemonic. Next. Which of the following is likely cause of the professor's abnormal thyroid function test? 60-year-old elderly male presents, he is a professor in the endocrinology clinic, presents with the ER, acute shortness of breath after transatlantic flight. He has otherwise been quite well. Examination reveals pulse is 102 beats per minute. Oxygen saturation is low, 90% on room air, and he has a BP of 118 by 90. Legs appear normal, chest is fine. Clinical suspicious of pulmonary embolism, he is commenced on heparin therapy, and this is confirmed by VQ scan. Given his occupation, thyroid function tests are performed despite no overt features of thyrotoxicosis and result revealing TSH normal, free T4 is 43.4 high, free T3 is 6.7. Which of the following most likely cause of professor's thyroid function test? Graves, subclinical hyperthyroidism, toxic thyroid nodule, heparin treatment, Hashimoto's thyroiditis. Hashi is hypo, heparin treatment.
So the patient had high 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 في الفري صح؟ والT3 is
T3
within normal
is
range.
normal. Yeah.
And this
54
one,
بس.
TSH is normal. Is it not factitious? But we don't have factitious. He was not on any thyroid replacement. So is it subclinical hyperthyroidism? Pre T4 is high.
subclinical this TSH will be high.
Normal. Normal.
It's
Pre
normal. It's normal.
TSH will be high صح؟ والله ما عارفة جابها شنو ده؟ after transit flight he has T3 low ده sick ولا شنو ده؟ ولا هنا graves subclinical هم أدوم medication عنده خلاص ده الهيبرين يمكن الهيبرين بيعمل كده عنده كان on the clinical suspicion of pulmonary is commenced on heparin and is commenced on VQ scan هيكون الهيبرين can code like this
By exclusion, yeah.
By exclusion only.
heparin.
Okay, heparin causes the false rise in free T4 due to displacement on assay. Heparin is having an in vitro effect on thyroxine level. IV heparin interferes with the thyroid function test assay on occasions, displacing bound thyroid hormone. These test results are not compatible with a primary hyperthyroidism as the thyroid stimulating hormone is not suppressed. Subclinical hyperthyroidism would have low or suppressed TSH or normal T4 levels. Okay. Which of the following is the most appropriate investigation in determining the etiology for this patient diabetes? Most appropriate investigation in determining the etiology, the cause of DM. 52-year-old male presents with a 6-month history of weight loss and thirst. He has a past history of hypertension for which he takes benzoflumetazide and tramiprin. Otherwise, he has been well. He has lost approximately 4 kg in weight over this time and finds that he needs to get up in the night to pass urine twice. On examination, his pulse is 80 regular, BP 138/84 and BMI is 23.5. Dipstick urinase shows 2 plus glucose. Fasting blood glucose is 13.3 high. HbA1c is high. Which of the following is most appropriate investigation determining the etiology? HLA typing, glutamic acid decarboxylase antibodies, insulin autoantibodies, urine-free cortisol measurement, tryptophan hydroxylase autoantibodies.
Get it.
For type 2 diabetes mellitus, GAD antibodies.
لا
Type 1 because he has weight loss.
لا
لا
Was
get
BMI was
on
22.5. Okay, 70 to 90% of the patients with the type 1 diabetes mellitus will have anti-GAD antibodies. This patient has a diabetes mellitus in view of weight loss. This weight loss I did not document. Okay, non-obese and osmotic symptoms is likely to be insulopenic type 1. The presence of GAD antibodies would signify an autoimmune etiology, and their presence signifies a tenfold increased risk of developing insulin-dependent diabetes mellitus being found in 90% of the type 1 DM. This would be the case of latent autoimmune diabetes mellitus in adults, LADA, and constitutes approximately 10% of the patients incorrectly labeled as type 2 diabetic. Okay. Also, one might encounter a high prevalence of islet cell and autoantibodies in type 1 diabetes. Insulin antibodies are found almost exclusively in young children with type 1 DM. Tryptophan hydroxylase and autoantibodies may be found in autoimmune polyendocrine syndrome associated with an autoimmune malabsorption. Discussion points. What HLA types are associated with both? Okay, which of the following is correct way to manage her blood pressure? A 62-year-old woman comes to the diabetes nephropathy clinic for review. She is known to have a chronically elevated creatinine and microalbuminuria. Medication includes basal bolus insulin, ramipril 10 mg, amlodipine 5 mg, bisoprolol 10 mg. Her BP is 155 by 72, pulse is 72. She has neuropathy to the mid shin. Hemoglobin is normal, lowish normal. White cell count is normal. Platelets normal. Sodium 138. Potassium 5.2 higher side. Creatinine also high. Renal impairment. So which of the following is correct way to manage BP? Add indapamide, add doxazosin, add diltiazem. Exchange her ramipril for doxazosin, exchange her ramipril for indapamide. Patient already on AC inhibitor with renal impairment and she is DM with the peripheral neuropathy.
Diabetic, what's you say?
A patient has a
Patient
DM
with?
with patient has a DM with complication with microalbuminuria, nephropathy, and peripheral neuropathy with uncontrolled BP. So the question here
Maximum
is,
dose of ramipril.
what is which of the following correct
BTP.
manage her BP? She has BP 155 by 72.
هي على أملوديبين خلاص إلا أنت بمايد يا
Yeah, add
ولا
intermediate, yes. Diuretic.
Exchange ramipril or not?
رامبريل متغير عندك
Patient
بروتينوريا
needs AC inhibitor, doctor. Patient needs AC inhibitor.
Whatever is
عندها بروتينوريا لازم تغسل الرامبريل بدها سازاي ACD الجديد.
Indapamide enhance potassium excretion and not contribute to edema, and so is useful in the management of blood pressure control in kidney disease. Doctor, recently there is a study that indapamide will increase uncontrolled blood sugar. It has no control on the sugar.
Yes.
Mm.
It's
So, but the
controllable.
question is
Characteristics.
asking, yeah, the question is asking what is the other way, correct way to manage the BP. Okay. This woman has a chronic renal impairment as a result of her diabetes and her creatinine also slowly rising over the past year. The most likely explanation is progression of her diabetic nephropathy. As such, the ramipril should be continued if possible. Or the options given, of the options given, indapamide is the best choice as it will enhance potassium excretion and not contribute to edema. The options to exchange the ramipril for another antihypertensive are not appropriate as her ACE inhibitor should be continued if possible. Of the other choices, only indapamide will have a positive effect on her potassium. If her potassium were in the normal range, then diltiazem may be an option. As small studies have demonstrated an impact on reducing the proteinuria. Okay. What is the most likely diagnosis? A 50-year-old female presents with palpitation, slight weight loss. Palpitation, weight loss. She has an uneventful medical history but takes supplements that she buys in health food shop. She's a non-smoker, drinks little alcohol. There is a maternal aunt who has underactive thyroid, but nothing else note in the history. On examination, she has a pulse 96 per minute, BP 122/76. She has a fine tremor of outstretched hands, and there is a slight lid lag, but no exophthalmos. No goiter palpable. Free T4 is high. Free T3 is 5.3. TSH suppressed 0.02. Thyroglobulin is undetectable. What is the most likely diagnosis? Her free T4, free T3, high with a suppressed TSH, and she has no goiter, no exophthalmos, but a slight lead lag with hyperthyroid symptoms of palpitation and weight loss. Is it not factitious because her maternal aunt has underthyroid? Yes, factitious. Yes, maybe she is taking from maternal aunt. Yes, factitious. Yes, D. Okay. Thyroglobulin measurement helps differentiate factitious thyrotoxics from other diagnoses. All other possible causes, but undetectable thyroglobulin clinches the diagnosis of factitious hyperthyroidism. Thyroglobulin in the precursor of thyroid hormone. Thyroglobulin is a precursor of thyroid hormones. Therefore, if undetectable, indicates an external source of thyroid hormone has been administered, like a C-peptide. Okay. Which of the following is the most appropriate advice to give regards of her insulin dose? Which of the following most appropriate advice to give regards the insulin dose? You are reviewing a 70-year-old type 2 diabetic lady. She takes metformin 1 gram BID and also has a humulin I insulin taken once daily at night. The insulin was started at her last diabetic review, and she has been monitoring her glucose level at home and to aid the dose titration. She tells you that her waking glucose level at home have been in the range of 9 to 13 millimole, which is uncontrolled fasting glucose over the last 1 2 weeks. Over the last 1 to 2 weeks, 9 has been the lowest reading she has had. She's currently taking 20 units of insulin at night. Which of the following is the most correct advice? Increase her insulin dose by 20 units. Increase her insulin dose by 2 units. Increase her insulin dose by 4 units. Move the insulin dose to the morning. Increase her insulin dose by 10 units. The C answer, increase her insulin dose by 4 units.
اثنين في المية اثنين 2 unit
2.
10% صح؟ You increase by 10% and decrease by 20. You want to increase, yeah.
Increase, okay.
Increase by 2%.
Yeah. Okay. Wake up titrating insulin increase the step up by 10%. Generally, insulin doses are increased to 10% increments. In this case, we have a patient on a once daily insulin whose sugars are running above the target range. Pre-breakfast glucose readings should be ideally be between 4 to 7 millimoles. She therefore requires her insulin to be increased. Using the 10% rule for up titration of insulin, she should be added 2 units to her current dose. Further monitoring pre-breakfast glucose level will guide any further dose adjustments. 10% rule. Yes, yes. Which of the yes, which of the following correctly fits with the mode of action of denosumab? Direct question. It decreases the osteoclast formation, decreases calcium excretion, decreases osteoclast formation. Yeah, direct question. This was a part one question actually. Denosumab is a rank ligand inhibitor used in osteoporosis, which works by reducing the osteoclast formation. Denosumab is a rank ligand inhibitor. Rank occurs on the surface of osteoclast precursors and osteoclasts. Inhibiting it leads to reduced clast formation and function survival. This leads to reduced bone resorption in both cortical and trabecular bone. Denosumab does not directly affect changes in calcium absorption or excretion and does not affect osteoblast function. Denosumab osteoclast decreased. Yeah. The serum specimen was obtained in 46-year-old male admitted under the care of surgeons. What is the explanation of for this appearance? Apoprotein, yeah, lipoprotein lipase deficiency, yes. Lipoprotein lipase deficiency will produce chylomicronemia and hypertriglyceridemia. This milky-looking serum sample is due to hyperchylomicronemia, hypertriglyceridemia, and is a consequence of deficiency of lipoprotein lipase. Xanthoma and lipemic retinalis are features of pancreatitis and gout occur. It can occur as a primary condition due to rare autosomal recessive loss of LPL, or more commonly serious is secondary to disease such as pancreatitis, hypothyroidism, type 1 DM, alcoholism, Cushing syndrome. Apolipoprotein C uh, 2 deficiency, a rare autosomal recessive hereditary disorder, is an inhibitor to lipoprotein lipase and may cause this type of appearance, but is extremely rare and manifests in childhood. Tangier disease is an extremely rare autosomal recessive metabolic disorder. Characteristics of Tangier's disease include decreased levels or even complete absence of high HDL concentration in the plasma, low cholesterol level in the plasma, increased cholesterol esters in tonsils, spleen, liver, skin, lymph nodes. This is a multisystem disorder with lipids. One easily seen characteristic usually found in the children with the Tangier's disease in the presence of enlarged yellow-orange tonsils. Tangier's disease, tonsils enlargement. Hepatic low LDL receptor deficiency is a feature of familial hypercholesterolemia. Oh, okay. Which of the following investigations would you select for further investigation? A 42-year-old male presents with the impotence and reduced libido, 6 months duration. He has been married 15 years and has 2 children. Secondary hypogonadism. Okay. He smokes 5 cigarettes per day, drinks approximately 12 units of alcohol weekly. Examination reveals an obese male who is phenotypically normal secondary sexual characters. Hemoglobin normal, WC normal, platelet normal, electrolytes normal. Fasting glucose is 5.6, LFT normal, T4 is normal, TSH normal, prolactin 259 normal, testosterone 6.6 low, LH 23, FSH high. MRI pituitary of the diagnosis, doctor, here this is due to sarcoma.
No, it is primary testicular failure because you have here increased LH, increased
Hypergonadotrophic hypergonadism.
Hypochondroplasia.
Hypergonadotrophic. Yes. So you should do ultrasound of the testis.
Primary hypogonadism is associated with a low testosterone and sperm count with appropriately elevated LH, FSH. But as he had children, I think. So, this patient in the history married 15 years and
Had
had
children. And yes, you mean what you mean? You mean primary testicular failure can come to the one who was already
okay.
before.
Yeah, okay, fine. Primary hypogonadism and is associated with a low testosterone level and sperm count with appropriately elevated LH-FSH. The patient has a hypergonadotrophic hypogonadism suggesting primary gonadal failure. The patient has a primary hypogonadism if the serum testosterone concentration and the sperm count are below normal and the LH-FSH are above normal. The patient has a secondary hypogonadism if the serum testosterone concentration and sperm count are subnormal and serum LH, FSH concentrations are normal or reduced. Subnormal and reduced. Primary hypogonadism is more likely to be associated with a decreased in sperm production than in the testosterone production. Although many testicular disease damage both seminiferous tubules and Leydig cells, they usually damage the seminiferous tubules to a greater degree. As a consequence, the sperm count will be low, the serum FSH concentration normal or high, yet the serum testosterone concentration remains normal. In contrast, in secondary hypogonadism, there is a proportionate reduction in both testosterone and sperm production. Testicular tumor infiltrations or idiopathic failure may be suspected. Ultrasonographic evaluation, yeah, this is what I was expecting. Testicular tumor infiltration, idiopathic failure may be suspected, and ultrasonographic evaluation of the testis is the modest appropriate investigation. Hemochromatosis usually cause pituitary dysfunction, and MRI of the pituitary is not indicated as the pituitary is behaving appropriately. A karyotype for Klinefelters is not necessary in this patient with the 2 children, and mosaicism would be very unusual. Causes of primary hypogonadism in males can include congenital abnormalities and acquired diseases. Congenital abnormalities, Klinefelters, mutation in FSH LH receptor genes, cryptocortism, varicocele, disorders of the androgen synthesis, and myotonic dystrophy. Acquired diseases are infections, especially like mumps, radiation, alkylating agents, glucocorticoids, environmental toxins, trauma, testicular torsion, autoimmune damage, chronic systemic illness, hepatic cirrhosis, chronic renal failure, AIDS, and idiopathic. What is a rash? Patient is admitted with a 2-month history of abdominal pains, watery diarrhea, and has noted extensive rash. GA symptoms with rash.
جلوكونوما دي أيوة
This
ميجريتال
yeah, necrotic migrating erythema.
أيوة دي جلوكونوما.
Okay, glucogonoma is associated with a necrolytic migratory erythema. The symptoms with this rash, which is typical of necrolytic migratory erythema, suggest a glucogonoma. The other features are DM, hypoaminoaciduria, aminoacidemia, hypoaminoacidemia, chiliosis, normochromic normocytic anemia, venous thrombosis, neuropsychiatric features. At least 50% or metastatic presentation as prognosis is very poor. Acquired ichthyosis appears as a symmetrical scaling of the skin and is a cutaneous manifestation of underlying malignancy. Erythema migrans is associated with Lyme disease. Erythema ab igni livedo reticularis has appearance of chain mail. Erythema repens gyratum is another paraneoplastic phenomenon commonly occurring with the lung, breast, stomach, etc. What is the most appropriate treatment? A 58-year-old lady with type 2 diabetes mellitus and chronic renal failure on hemodialysis presents with unstable angina. She currently uses twice daily insulin for glycemic control, but control has been poor of late. Okay. Hemoglobin is low, MCV normal, platelet normal, white cell count normal, hemoglobin A1C is very high. What is the most appropriate treatment? Is start insulin. Uncontrolled sugars, huh? Yeah, patient has unstable angina on with CRF with on dialysis, unstable angina with poor glycemic control, should start on insulin. Oral ferrous sulfate, subcutaneous erythropoietin and intravenous iron, blood transfusion with 2 units of packed RB cells, subcutaneous erythropoietin, intravenous iron infusion.
Blood transfusion.
Subcutaneous erythropoietin.
No, blood transfusion.
You will treat the
Symptomatic
anemia.
anemia. I have to give a blood.
You will treat the anemia for unstable angina.
Yes, I'll give blood.
Yes. To back the RBCs.
Even if 86, I will do blood transfusion.
Blood transfusion, yes.
Blood transfusion patient came with symptoms بتاعت anemia.
Unstable angina, yes.
Unstable angina.
Mm. Yes.
Okay. The guidelines suggest maintaining hemoglobin more than 11 grams in CRF. I think it was 12 in PACES in past medicine. The aim in all patients with a chronic renal failure to maintain the hemoglobin concentration is above 11 grams. It is important to correct the anemia as it leads to ventricular hypertrophy, which increases the cardiovascular morbidity and mortality. This patient exhibits the signs of severe anemia, angina. This may or may not be treated to underlying coronary artery disease. The treatment of choice is an urgent blood transfusion to treat the ongoing symptoms. If this patient did not have symptoms, the correct answer would be subcutaneous erythropoietin and intravenous iron. If IV iron therapy should be given following a small IV test dose to exclude anaphylaxis and subcutaneous erythropoietin to enhance erythropoiesis and increase the hemoglobin concentration. If the patient did not respond to this dual regimen, she should be investigated for sepsis, chronic blood loss, non-compliance of treatment, severe hyperparathyroidism, which can cause marrow fibrosis. Okay. From the history of MRI appearance, what is the most likely diagnosis? The MRI scan of a 22-year-old female who presents with a 6-month history of secondary amenorrhea. She is otherwise well. There is no abnormalities on physical examination. PCOD, acromegaly, microprolactinoma, Kalman syndrome, non-functioning pituitary tumor. Patient has a cellular distension.
Microbe electron.
Yes. Lesion less than 1 centimeter in pituitary and hyperprolactinemia is microprolactinemia. The MRI scan with contrast reveals a slight hypointense abnormality on the right side of the pituitary as we look at it. Can you please open the image, doctor? No, we can open from the on examination itself. The above image.
I couldn't open it.
No, no,
What do you want
about the
to
top
know?
one, the top one.
This one?
Ah,
Here or what?
we cannot open this. We cannot click on this.
No, I couldn't.
Ah, okay. Okay,
Mhm.
so in the explanation, it shows in this case, MRI scan with contrast reveals a slight hypointense abnormality on the right side of the pituitary as we look at it. In this case, the pituitary history of secondary amenorrhea and the small less than 1 centimeter lesion is likely to diagnose is a microprolactinoma. It may be accompanied by galacturia, but this is not.
Mm.
Mhm.
No problem. Yeah, it's connected. Mhm.
But this is not a absolute. A 55, what is the most likely to improve her life what is the most likely to improve her life expectancy? A 55-year-old woman found to have glycosuria and had a maternal history of type 2 diabetes mellitus. She is a smoker of 20 cigarettes per day. Examination reveals no specific abnormalities apart from BMI of 30, BP is 130 to 88, serum creatinine is 80, plasma glucose is high, total serum cholesterol, upper limit high, HDL 1.4. What is the most likely to improve her life expectancy? Patient has a DM type 2 with hyperglycemia and high cholesterol. So we have to add statins. Simvastatin 10 mg, Ramipril 10 mg, weight loss to achieve BMI of 25, metformin 500 mg twice a daily, stop smoking. Life expectancy is to avoid MI. So, yeah,
Mhm.
if you stop smoking, that will control the cholesterol also. Smoking cessation will have greatest impact on CV risk in diabetic obese population. She is diabetic and obese. She is almost prone to risk of cardiovascular disease, with evidence suggesting that people with diabetes have at least two to four-fold. Mhm. Yeah,
Mhm.
fourfold increase in cardiovascular mortality. In terms of improving life expectancy of the risk factors mentioned, diabetes, mild dyslipidemia, and hypertension, stop smoking would, without question, be expected to have a greatest benefit. Tight glycemic control, unfortunately, does little to reduce the CV cardiovascular risk. Uh, and statin therapy would be expected to have a small but significant impact in this patient according to the primary prevention studies. Smoking cessation is good. Stopping smoking is the first priority, even if they cause further weight gain. Smoking is associated with a CV cardiovascular risk of 6 times in women and 3 times in men. Stopping smoking uh, reduces the risk of recurrent MI by 50%. Okay, which investigation is the most appropriate? A 32-year-old woman presents with a 4-month history of amenorrhea. She takes no specific therapy. She had 2 children and her husband had a vasectomy. Examination revealed obese individual but no other abnormality. Serum estradiol is 100. Estradiol is 100 low. And serum LH is 2.1 low. FSH low. And prolactin 800 above normal, and serum testosterone is 2.1 low, all low. Which investigation is most appropriate? Pregnancy test, magnetic resonant MRI of the pituitary, 17 hydroxyprogesterone, insulin tolerance test, urine free cortisol concentration. She's obese with hypogonadism.
MRI. Okay.
Hypogonadism in the presence of raised prolactin is likely secondary to microprolactinoma. This patient has a hypogonadism as evidenced by the suppressed LH, FSH, and a low estradiol concentration. This would exclude pregnancy as a cause, and polycystic ovarian syndrome is unlikely. In the presence of raised prolactin concentration, the microprolactin would be the most likely explanation for this patient's symptoms and results. This may be demonstrated with pituitary MRA. An insulin tolerant test would be usually entirely normal in microprolactinoma. Urine-free cortisol would be helpful to screen the Cushing syndrome, but does not help in making the diagnosis. MRI is the best. Next. What is the most appropriate treatment for her hirsutism and her underlying condition? A 22-year-old woman presents with a 5-year history of hirsutism and her having noticed coarse dark hair under the chin. Being teacher in primary school, these symptoms are distressing to her. She has tried all the local measures, shaving, applying depilatory creams, but without lasting success. Her periods are irregular, oligomenorrhea. She attained a menarche at the age of 14. She has not yet conceived. Takes 5 mg of diazepam at night. On examination, she had a BMI of 26. She had a coarse dark hair over the chin, lower back, and either thighs. She does not have galacturia to express, and there were no other clinical features to suggest Cushing's. Serum androstenedione is 10 high. This is PCOD, right? Dihydroandrostenedione sulfate is 9.6 normal. Serum 17 hydroxyprogesterone is 5.6 normal. Estradiol is normal, and testosterone normal. I mean, above the upper limit of the normal. Serum sex hormone binding globulin is 32, lowish. Plasma LH is 4.8 normal. FSH 2.5 normal. Prolactin 380. Bromocriptine, clomiphene, metformin, OCP, carboguline. OCP. Yes. OCP. PCOD. Hirsutism OCP. First line therapy. PCO has traditionally been preparation has the preparation of Dianate, which contains ethinyl estradiol in combination with the cyproterine acetate 12 milligram. Okay, the most appropriate treatment for this woman has polycystic ovarian disease. The most prominent feature being hirsutism would be OCP. The first line therapy has traditionally been preparation of Dianate, which contains both ethynyl estradiol in combination with the cyproterone acetate. And hyperprolactinemia in this case is with normal estradiol would be most likely be functional hyperprolactinemia associated with the PCOS rather than due to any prolactin secreting pituitary disorder. The significance of sex hormone binding globulin protein in this is that sex hormone binding globulin is lower in PCOS. The reasons include the androgens reduces the globulin production, whereas estrogen promotes the production. It is a protein for transport of hormones in the blood.
I don't know. Meaning 7.
Mm.
Mm.
Okay, what is the correct choice of IV fluid treatment at this point? Correct choice of IV fluid, okay. 65-year-old elderly man brought to the ER, found collapsed and semi-conscious at home. He is unable to give any coherent history, has no family assistant. On examination, GCS is depressed, 10, pupils reactive, there are no localizing neurological signs, and cranial nerves are intact. He has a temperature of 38.5, dehydrated, has a pulse rate of 125, BP is 110/60, associated with postural drop approximately 10. On auscultation, precordium heart sounds 1 and 2 are normal, no murmur, tachypneic, hypoxic. Saturation is 89% only. On room air, right lower zone dullness to percussion with the coarse breath sounds. His abdomen is soft, audible bowel sounds. Ophthalmoscopy shows some microaneurysm and exudates. The ER nurse dipsticks urine shows 3 plus glucose and finger blood glucose greater than 40. Emergency blood gas results, other biochemistry are shown. Serum sodium is high, potassium is high also. Chloride 100 normal, bicarbonate 20, acidosis, serum urea, creatinine, renal impairment. Sepsis with hypotension, patient deteriorating, yes. With high blood sugar, DKA. Plasma glucose is 45 millimole, HbA1c is 74, 8.9% uncontrolled. Blood gas analysis on the air shows 7.39, PaO2 is 8, PCaO2 is 44.2, base excess -4, plasma lactate is 2. He has been given enough normal saline to match the initial fluid deficit. However, despite this, sodium remains high. What is the correct choice of IV fluid treatment at this point? 0.4%, 5% dextrose, gelofuscin, dextrose saline, 0.9% saline.
half saline لأنه diabetic ولا despise الصوديوم remain
Yeah,
remain high.
hyperglycemia, hypernatremia, yes.
Mm.
Dehydration, yes. Yeah, the initial management of his HHS is with IV rehydration and later addition of insulin if required. The patient has a hyperosmolar hyperglycemic coma with a calculated osmolarity of 420 milliosmoles. The formula is given with the 2 sodium, 1 potassium, glucose, and urea as it is. And in the absence of ketonuria, this is likely to have been precipitated by pneumonia. This state occurs in older type 2 diabetes mellitus patients, some residual insulin production preventing the development of ketoacidosis, which occurs in type 1 DM. Consequent on the osmotic diuresis due to hyperglycemia, the patient will be very dehydrated. The initial goals in is repletion of extracellular volume with 1 liter of normal saline will start to restore this as it remains in the extracellular compartment. This is suggested by the mild hypotension and absent postural drop. If these were still persistent, this would indicate a need for further volume expansion. Once this has been achieved in patients who are hyperosmolar, as in this case given, the hypernatremia, the appropriate agent is 0.45%, 1/4 saline, which replaces intra and extracellular fluid loss, which is similar in composition to fluid lost during osmotic diuresis. 5% dextrose should be added when blood glucose reaches 15 millimole. Electrolytes should be checked 2 to 4 hourly, aiming a decrease of sodium no quicker than 10 millimoles per day. Patients managed in high care environment. Patient presented with a 3-month history of gradually enlarging rash on her foot. She had a past history of rheumatoid arthritis. Urine dipstick is negative. Fasting blood glucose was normal. What is the most likely diagnosis? Squamous, neuropathic, Necrobasis lipoidicum, yes, yes. Necrobasis lipoidica is a commonly associated with DM, painless lesion, and secondary to collagen degeneration. Necrobiosis lipoidica is a disorder of collagen degeneration with the granulomatous response, thickening of the blood vessel walls, and a fat deposition. It is usually related to diabetes, can also occur in patients with rheumatoid arthritis, as in this patient. Necrobiosis may precede symptoms and signs of DM by several months. The exact cause of necrobiosis is unknown, but the leading theory of necrobiosis in diabetes has focused on diabetic microangiopathy. Necrobiosis is often mistaken for eczema, but rather than responding to steroids, it may actually deteriorate. Occasionally, ulceration of the lesion will occur, is typically painless. Signal drop. Yeah. So, what is the most appropriate treatment for this patient? 72-year-old elderly male presents to 2-month history of agitation and weight loss. Agitation, weight loss. Elderly male. 4 months previously, he was admitted to paroxysmal AF, was commenced on amiodarone. Since then, he has no further palpitation. He has otherwise been well with a past history of hypertension for which he takes amlodipine. On examination, he looked well, has a slight tremor of the outstretched hands, pulse of 88 beats per minute, regular, and BP is 164 by 88. No goiter was palpable. There were no eye signs. Hemoglobin normal, white cell count normal, platelet normal, ESR normal, serum sodium normal, potassium normal, urea is normal, creatinine normal, free T4 is high, free T3 is normal, TSH 0.07, lowish. Thyroid autoantibody is negative. What is the most appropriate treatment for this patient? Start prednisolone, start carbamazole, treat with radioactive iodine, stop amiodarone, start atenolol. Agitation, weight loss with the free T4 high, T3 is normal, TSH suppressed.
Amiodarone-induced cytotoxicosis type 2.
But he has no goiter. Yes,
That
type
means
2.
type 2.
Stop amiodarone. Okay, amiodarone-induced thyrotoxicosis may be due to thyroiditis and can be treated with the steroids or withdrawal of amiodarone. The patient has amiodarone-induced hyperthyroidism, a relatively common problem. The patient commenced amiodarone due to paroxysmal AF, but other agents such as sotalol may be more appropriate. Therefore, the most appropriate treatment would be withdrawal of amiodarone. There is no evidence to support restrictive thyroiditis, relatively normal ESR. Oh, yes, ESR missed here. Okay. Relatively normal ESR with a slightly elevated thyroid function test. So, steroids or steroids are not necessary. We should have looked for ESR. It is normal here. The radioactive iodine uptake scan would probably not show any uptake as amiodarone is stuffed with iodine. So, radioactive treatment would be ineffective as well as unnecessary. What treatment would you advise? Treatment. A 56-year-old female presents to the GP with a tiredness of 3 years duration. No specific abnormalities are found eventually. and GP undertakes some blood tests. 3 years of tiredness. He is surprised to find an elevated calcium concentration and refers the patient to you. She has been well, but has been depressed of late since the death of her elderly parent. In her past history, she states that her elder brother and his son has some calcium problem diagnosed approximately 6 years ago, although to her knowledge they have not received any treatment. She takes only atenolol for hypertension, but receives no other therapy and does not take any supplements. Examination reveals BP 148/96, but no other abnormalities are noted. Serum sodium is 138, potassium 3.8, urea is 7.1, calcium 2.76, phosphate 1, alkaline phosphate is 100, parathermone
Familial
4.4,
hypertension.
normal. Urine calcium is 1.2. What treatment would you advise? Parathyroidectomy, loop diuretic therapy,
No
bisphosphonate
treatment.
therapy, no treatment, low calcium diet. Nothing is supportive, no treatment.
Yes, no treatment.
Familial hypercalcemic calciuria is an autosomal dominant. It runs, patient has a mild hypercalcemia with a normal parathermone. Alkaline phosphate and reduced urine calcium. Together with the family history of calcium problems, a diagnosis of familial hypocalciuric hypercalcemia is suggested. This condition is associated with autosomal dominant and is consequence of down regulation of the calcium receptor, resulting in compensatory hypercalcemia. FHH is often misdiagnosed as a primary hyperparathyroidism, but may be distinguished from later by the positive family history. Unlike hyperparathyroidism, it is not associated with any specific abnormality. How should the oral glucose tolerance test is performed in diagnosis of diabetes? Any luck? Any guess? After 2 hour fast,
75
take a blood. Huh? This is with the 75 grams glucose we have to give, sir.
overnight fast. We have
Yeah. After an overnight fast, blood sample for glucose, give 75 grams of anhydrous glucose and take further sample in 120 minutes. 1.5 hours, yes. This is straightforward. You have to read. Oh, it's a big.
Please wait.
Yeah. What would you advise with respect management of his steroid therapy? What would you advise with respect to management of steroid therapy? Most probably as antidote. 70-year-old male presents with the emergency department with pneumonia. He suffers from classical congenital hyperplasia due to 21 hydroxylase deficiency. Current medication includes prednisolone 7.5 mg daily, fludrocortisone 100 microgram daily. On examination, his temperature 38.2 and BP is 90/65, pulse is 95, regular. He has the signs of left lower lobe pneumonia. Hemoglobin is normal, bedside count elevated, platelet normal, sodium is lowish, potassium 5, creatinine 122 high. What would you advise? He should maintain his current dose of corticosteroid. He should transition to IV hydrocortisone and maintain his mineralocorticoid dose. He should increase the dose of oral corticosteroids by 50% and keep the mineralocorticoid dose the same. He should double his dose of oral corticosteroid and oral mineralocorticoid. He should keep his dose of oral steroid the same and double the dose of mineralocorticoid. This is the third, sir, because patient is in stress, pneumonia. His requirement of steroid is high, 50%. We have to increase, sir. No. IP hydrocortisone. Switch only. This is oral. The third answer is oral.
Not
Steroid.
doubling, not
No,
double
no,
the dose.
no. He asking
He
change
just
the IP form.
only transition to IV. maintain
IV
maintain
form.
corticosteroids, yes, you know, but only transfers oral to
IV.
IV. No doubling.
No. Leaving both the corticosteroid and melanocorticoid dose unchanged.
He's treated in hospital or at home.
He is hypotensive, febrile, septic.
He's in crisis now.
Score is high, creatinine high already. His
He's
temperature.
breathing in ER, you have to give hydrocortisone IV.
Yes.
I'm not admitted يعني.
Yeah.
He's
Leaving
in
both
crisis now.
Leaving both corticosteroid and melanocorticoid dose unchanged is inappropriate on long-term steroids who present with infections. Given this patient has a relatively severe pneumonia and is hypotensive, the most appropriate action is to convert him temporarily to IV glucocorticoid. Conventionally, 50 to 100 milligram of hydrocortisone 6 hourly. Dose melanocorticoid is maintained. For milder concurrent illness, oral prednisone is usually doubled. For milder, but this patient is severe, so we have to change to IV forms. Melanocorticoid dose is always left unchanged. Leaving both corticosteroid and melanocorticoid dose unchanged is inappropriate. Next. Which of the following is the most appropriate treatment for her hirsutism? Once again, another PCOD. A 19-year-old younger female student presents to the endocrinology clinic with excessive hirsutism. She also suffers from acne, for which she was given 3-month course of doxycycline by previous GP. Her periods are irregular, tend to be heavy. Over the past 6 months, modest weight loss and has been achieved, but she finds it difficult to lose her weight. Further weight. On examination, BP is 132/72, pulse is 67, regular, BMI is 27, high. She has excessive hair growth over her beard, mustache line, over her upper chest and lower abdomen, acne spreads over her face and neck. Hemoglobin normal, WBC platelet normal, sodium normal, potassium normal, creatinine normal, testosterone is 4, high, LH is 100, high. Which of the following is most appropriate treatment for hirsutism? Pioglitazone, clomiphene, metformin, spironolactone, Danette. Next. Next. We read the explanation already. Yes. Last question. Okay. Prior to the results of her emergency blood tests being available, what is the most appropriate immediate treatment for this patient, ER patient? Okay, a 80-year-old female presents to the ER acutely unwell after being found unresponsive on the floor of her house by her son. She had a past history of hypothyroidism and of taking thyroxine daily. However, her compliance with the treatment is questionable. On examination, she was unarousable, glasgow scale is 6, had a central temperature of 34, hypothermic, comatose, saturation is 95, pulse is 44, brady, BP is 100/80, normal. There were no specific localizing signs on neurological examination, but both plantars were extensor. So what will you give? Intravenous 50% glucose, IV hydrocortisone, EV normal saline, oral thyroxine via NG tube, intravenous thyroxine T3 and hydrocortisone.
Hydrocortisone.
Yeah, myxedema coma, this one. Patient is myxedema comatose. She has not complied with medication, so she was hypothyroid, so she went into coma, myxedema coma. So we have to replace urgently the steroid as a stress response and give the thyroxine. Yeah, myxedema coma is a medical emergency requiring treatment with IV, thyroxine, and hydrocortisone. This patient has typical feature of coma, which usually myxedema coma, which usually occurs in the elderly who are typically non-compliant. It carries a high mortality and should initially be treated with IV thyroid hormone, either T4 or T3, and IV hydrocortisone even before results are obtained. Other treatment include rewarming, IV fluids, uh, should be cautiously used, and these patients are typically fluid overloaded.
Thank you.
Thank you, doctor. See you tomorrow,
Thank
inshallah.
you. Thank you.
Okay.
Bye bye.
Okay.